Acute mastoiditis. Acute mastoiditis is an infection of mastoid air cell system, and this may arise as a complication of acute otitis media. The common causative organisms are generally Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis. Less common organisms are group A Streptococci and Staphylococcus aureus. What is the diagnostic criteria? Autalgia that is not settling with tenderness over the mastoid antrum. The external ear canal may be narrowed by edema of the posterior superior wall. A subperiosteal abscess can develop posteriorly behind the ear, pushing thereby the ear downwards and forwards. Often, these classic signs may not be present, leading to the term masked mastoiditis. Clinical suspicion of the presence of mastoiditis is required, and a CT or MRI scan is usually required to confirm the diagnosis. In the pathologic process of the disease, first there is an obstruction and sequestration of infection at the adytus, antrum, and the smaller air cell tracts. Now, after that, temporal or mastoid bone remodeling, resorption, and decalcification of bones may result. Postoral swelling. Postoral swelling with inflammatory signs such as redness, increased temperature is a classic presentation of acute mastoiditis. However, edema in soft parts behind the auricle is usually a late symptom. Otorrhea. Disease may cause weakened tympanic membrane which may rupture at some stage of the disease, and this may lead to develop acute otorrhea. Now, this discharge may be purulent and creamy in consistency. Pain. Some patients may develop pain in the mastoid region of the ear, although it is not a constant feature. Fever is a non-specific symptom, and this can result due to ongoing inflammation. Tenderness. Some patients may present with ear tenderness, which is commonly developed by the application of digital pressure on the mastoid process. Subperiosteal abscess. Progression of the inflammatory process will lead to this condition. When the suppuration escapes through the thinned out mastoid cortex and is entrapped by the periosteum as well as skin over the temporal bone and mastoid tip, it may cause development of subperiosteal abscess which is pointing superior to or directly over the mastoid tip. Sigmoid sinus thrombosis, a recognized complication of acute mastoiditis due to extension of the inflammatory process beyond the tympanomastoid system. Suppurative labyrinthitis and meningitis both are significant and life-threatening complications of disease which occur due to spreading beyond the tympanomastoid system, such as invasion of internal structures of the brain. Epidural, subdural brain abscess. These are serious life-threatening complications of acute mastoiditis which may result due to invasion of internal structures of the brain due to progression of disease. Facial paralysis. This sometimes are seen in affected individuals due to involvement of the facial nerve. Basal's abscess is a rare complication of acute mastoiditis and is a collection of abscess deep to the sternomastoid muscle. Now, history of recurrent otitis media. The disease found to be associated with recurrent otitis media. Usually, the mastoid air cells are in continuity with the middle ear space through the adytus and antrum. In acute otitis media, they are liable to get blocked by inflammatory reaction of the lining mucosa, and this will ultimately cause infected non-draining mastoid cavity, which may lead to develop into acute mastoiditis. Clinical examination will reveal a post-oral swelling, commonly detected sign on clinical examination, and can be fluctuant or non-fluctuant. Protrusion of the auricle and retroauricular cellulitis are classic features and essential for diagnosis. The anteroinferior displacement of the auricle can be noticed in affected patients due to underlying swelling. The post-auricular erythema, inflammatory features such as post-auricular erythema, redness can be detected in examination. Tenderness. Application of digital pressure on the mastoid process will produce tenderness. This may be elicited in all parts of the mastoid bone in some patients, whereas in others it is limited to certain areas only. Over the site of the antrum, which is behind the external meatus, tip of the mastoid process, as well as at the spot where the mastoid emissary vein perforates the bone, and are places where tenderness can be elicited. An osteitis or a periostitis of the underlying bone can be the reason to develop tenderness. Prolapse of the posterior superior wall of the meatus is not commonly seen, and extension of the inflammatory process in the underlying bone to the soft parts will cause this manifestation. If it is present, it might be an indication for surgery. Ear discharge. Otolaryngological examination will show purulent creamy ear discharge with perforation of the tympanic membrane, bone erosion. Erosion of the bone can be seen in temporal as well as mastoid bones, and later there will be bone remodeling, as well as bone resorption, as well as decalcification. Cranial nerve examination will show features of facial palsy due to involvement of the facial nerve. There may be hearing loss, as well as cranial nerves examination, I repeat again, will reveal conductive type of hearing loss. Now let's come to CT scan. Diagnosis is mainly clinical with the help of imaging such as CT, MRI. Temporal bone CT will show soft tissue density in the middle ear and mastoid cavity, as well as erosion and defect of cortical bone of the mastoid cavity. It may show sometimes contra-enhanced subperiosteal shadows. CT is often used in suspected cases of mastoiditis. Studies suggest that CT is able to distinguish between coalescent and non-coalescent mastoiditis with a high sensitivity as well as specificity. And also it is useful to diagnose other diseases which are mentioned under differential diagnosis. We will come to that later. Now, MRI is useful to determine intracranial complications. Also, MRI has a good accuracy for diagnosis of mastoiditis and concurrent subperiosteal abscesses. The T2 weighted images as well as contrast enhanced MRI are the types of MRI that can be used. Studies suggest that MRI has less accuracy to detect acute mastoiditis. Longer scan times, limited availability, and need for general anesthesia are the disadvantages of MRI compared to CT in pediatric population. Bacterial culture. Fluid can be extracted from the middle ear when there is a discharge. Gram staining and culture is carried out. Streptococcus pneumoniae, Streptococcus pyogenes are the commonly identified organisms. Now, culture may also be useful to start antibiotic and to select appropriate antibiotic type. Now, lumbar puncture may be performed in case of suspected intracranial spread, especially in case of meningitis. The other investigations include a full blood count. This is carried out to detect features of ongoing bacterial infection, as well as ESR. ESR elevation can be seen due to an ongoing inflammation. Blood culture can be performed when systemic inflammatory features such as fever is present. What is the specific management protocols? First, if there is a bulge, incision and drainage is one of the available surgical methods for acute mastoiditis. Combination of incision and drainage, ventilation, intravenous antibiotics has generally shown successful outcomes. Ventilation tube. Another available treatment option is the insertion of a ventilation tube, which is less invasive treatment modalities, and this can be considered prior to mastoidectomy to minimize anesthetic risk as well as possible adverse effects. The commonly found indication for simple mastoidectomy and ventilation tube insertion are patients who are presented with protruded mastoid abscess and the age of them over 30 months of age with weight more than 15 kilos. The presence of intracranial comorbidities as well as in patients who have a diagnosis to have colostoma are generally indications for further surgical interventions. Mastoidectomy. If incision and drainage, ventilation, myringotomy, and intravenous antibiotic treatments are not responding, then one could go in for invasive surgical operations such as mastoidectomy. It is usually performed 48 to 72 hours of conservative treatment. It is performed under general anesthesia. Simple mastectomy and ventilation tube insertion usually performed in case of associated complications such as mastoid abscess, in the presence of intracranial comorbidities, failure of 2-week antibiotic treatment in patients with granuloma, and suppurative otorrhea, as well as patients who are diagnosed to have cholesteatoma. Surgery carries a higher risk of complications such as permanent hearing loss and damage to surrounding structures. Shall we therefore conclude and synopsisize? The conservative management is an effective method in the treatment of non complicated acute mastoiditis, but myringotomy should be considered if there is no response within 48 hours. Cortical mastoidectomy should be used in conjunction with the medical management in the treatment of complicated cases. A review. The disease may cause significant and even life threatening complications beyond the tympanomastoid system, and these include subperiosteal abscess, Bezold's abscess, facial paralysis, suppurative labyrinthitis, meningitis, epidural and subdural abscesses, brain abscess, lateral sinus thrombophlebitis, and otic hydrocephalus. This picture shows on the left a post-auricular abscess without a fistula, and on the right with a fistula. This picture shows the CT of the skull that shows a subperiosteal abscess on the left, axial view, and on the right B, coronal view, with the arrow pointing towards the sigmoid sinus thrombosis. A brief overview of the mastoid air cells. Mastoid air cells are in continuity with the middle ear space through the adductus ad antrum, which is liable to be blocked by inflammatory reaction of the lining mucosa in acute otitis media, resulting in a non-draining infected mastoid cavity, while the middle ear can drain via the eustachian tube. Thus, the classic presentation of acute mastoiditis is a post-oral swelling with inflammatory signs. Clinical acute mastoiditis, the protrusion of the auricle and retroauricular cellulite is essential for diagnosis. At this stage or later, the weakened tympanic membrane may rupture and acute otorrhea can develop. Before destruction of mastoid bone, there is diffuse inflammation, acute inflammation of the underlying connective tissue of the mastoid cavity. Further progression of the inflammatory process within the mastoid space leads to destruction of the delicate trabecular system, resulting in coalescent mastoiditis. A subperiosteal abscess pointing superior to or directly over the mastoid tip occurs when the suppuration escapes through the thinned out mastoid cortex or by thrombophlebitis of an emissary vein and is entrapped by the periosteum and skin over the temporal bone and mastoid tip. Antibiotic treatment. Generally, all children are to be treated with intravenous antibiotic ceftriaxone in a dosage of 20 to 50 mg per kilogram body weight for at least 1 week, and this can be changed if necessary after culture results. Streptococcus pneumonia was the most common bacterium identified, followed by Streptococcus pyogenes, and this has been reported by many authors. Haemophilus influenza is one of the most frequent pathogens. It was not identified in culture of acute mastoiditis. However, several authors have reported that Haemophilus influenzae usually cause disease of the soft tissue and rarely progress to bone invasion. Generally, authors have selected ceftriaxone as the antibiotic of choice, as is usually active against most of the causative agents responsible for acute mastoiditis that were mentioned by many authors.